Thank you, Josh. Thank you, Sergio. Hello to everyone. I'm Giorgio Pochettino, a parent of two TANGO2 warriors, Edoardo and Carlotta. I'm also the co-chair of TANGO2 Research Foundation Research Committee and member of the board of directors. At this time, it's my pleasure to introduce our next speaker, Dr. Sam McKenzie from University of Rochester in New York. Dr. McKenzie is a clinician scientist focused on gene-based therapy for neurogenetic diseases affecting children. He spends his time taking care of children with neuromuscular conditions and is also actively involved in basic science and translational research in the lab. Dr. McKenzie is also the chair of TANGO2 Research Foundation Scientific Advisory Board and the newest member of the Foundation's Board of Directors. Dr. McKenzie, it's your stage. Thank you very much.
Thanks, Giorgio. All right. Well, I'm going to continue with some clinical updates, largely talking about two projects. One is kind of an ongoing movement disorders project that we're wrapping up that was funded by the TANGO2 Research Foundation, and just a review of a recently published case report from our center of the oldest known patient with TDD. And let's see if I can drive. Okay. So what are movement disorders? This is a kind of busy schematic that talks about, what centers of the brain, other parts of the central nervous system might be involved in movement disorders. So it's hard. I get a lot of referrals for movement disorders as a neuromuscular specialist. Nerves and muscles really don't play a huge role. Movement disorders largely come from something happening in the brain most of the time. And we separate these into hyperkinetic, where there's more movement than there should be, or hypokinetic, which you could think of somebody with maybe Parkinson's disease who's not on treatment. And you can see here that they come from different areas in the brain. If we were to kind of break these down and oversimplify things a little bit, there's a section of the brain called the basal ganglia. And that can give rise to something called dystonia, where muscle tone is increased. Again, not because of anything wrong with the muscle, but because of something coming from the brain. And then we also have the cerebellum, which contributes to ataxia. And I think we have another talk today talking more about the role of TANGO2 in the cerebellum. So we don't really know much about movement disorders or why they happen in TANGO2 deficiency disorder. But we think that, if we could figure out why these are happening, it might sort of inform what's going on with the disease more broadly. The other impetus for this project is that, as you've heard, a lot of children experience these spells, which we don't really understand. And we really wanted to get a better idea of what these are and if they might be consistent with other if these might be consistent with other movement disorders that we've talked about, such as dystonia or ataxia. And they might present an opportunity for early diagnosis. So part of this project, we looked at when these movement disorders occurred in a patient's life relative to things like metabolic crisis, because I think they can sort of serve as a canary in the coal mine for prompting genetic testing and getting patients on treatment. And then speaking of treatment, these could be something that we track, right, as a responsive symptom to therapeutic. And it's something that we need to get a better understanding of for clinical trial readiness. The problem with movement disorders in TDD is that they don't happen all the time. So this is supposed to give an analogy here. Lightning strikes, and it's hard to catch a snapshot of lightning with your phone. But what we could do, rather than bringing kids into a clinical setting and admitting them to the hospital for a month, we relied on videos taken by all of you. So the idea with this project was we asked people to submit their videos of abnormal movements that kids were having. They went to a secure server, and then we had a bunch of movement disorder specialists who are here on the right. So Jen Vermillion, Angela Hewitt, and John Mink, all at University of Rochester, all trained in pediatric movement disorders. And then Miriam Hull at Texas Children's, also a pediatric movement disorder specialist, helped out by Sammy Myers and Sarah Sandcooler on the left. So these movement disorder specialists reviewed all these videos that were submitted for 26 different patients with TDD. And a few patients also submitted baseline videos just so we could get a sense of what children looked like, at baseline. We didn't give them any other limitations in terms of how long or how many videos they could upload. And so at least three specialists independently looked at all videos and then categorized these into different phenomenologies, which just means, is this dystonia? Is this ataxia? Is this something else? And then we met as a group and we reviewed them again and came up with a consensus. And then we performed follow-up interviews with caregivers on the majority of these 26 patients. On average, people submitted about 5.5 videos, and we were able to call all of these either dystonia, ataxia, or TANGO2 spells. Importantly, and I've said this before, these TANGO2 spells don't look like they are a movement disorder per se, so they don't necessarily fit into a clear category of dystonia or ataxia. There's something else. So that's the terminology we're continuing with is the TANGO2 spell. All but one patient had movement disorders and or spells, and uh, multiple movement disorders or abnormal movements. So spells and dystonia, spells and ataxia, dystonia and ataxia. 2/3 of participants had more than one abnormal movement type after the point that we had interviewed them. So we weren't always able to catch that on video, but talking to parents, they said, "Oh yeah, they've also, I submitted this video of ataxia, but they also had spells when they were younger, for example." Importantly, I'm having a hard time with that word today. These abnormal movements were the first presenting symptom, I think similar to what you saw with the natural history study update in a little over half of participants, which does kind of solidify that idea that, yeah, maybe if we catch these early, this can give us a diagnosis before a child goes into metabolic or cardiac crisis. Crisis was the first presenting symptom for 5 patients, and developmental delay was the first presenting symptom for the other 5. And 14 participants had both movement disorders and metabolic crises, and there was a period of time where, in 8 out of 14, the average time in between these was, fairly long. So, there's a window there where if we can diagnose these movement disorders and send the appropriate testing, get that diagnosis, again, hopefully prevent the crisis from occurring. These have a big impact on quality of life. So 83% said that this, had a moderate to severe impact. And this isn't going to be a surprise to anybody listening, but sleep and feeding were commonly cited as things that helped these movement disorders resolve. And then looking at the B vitamins, we saw 70% either had full or partial resolution after starting vitamins. And the important point here is we haven't gone into the dosing, but we're very interested in looking at low dose versus high dose B5 and B9 and seeing if that made a difference. Unfortunately, some children with more severe neurological injury didn't necessarily have a large response to vitamins, and we think that's probably not related to the disease per se, the TANGO2 per se, but probably more related to that injury, which is harder to recover from with vitamin therapy alone. Let's advance. So here's just a way that I think about TANGO2 these days, and widening our net here of identifying patients. I think we are catching most of these patients in the middle. So if we think about less severe disease features versus more severe disease features, the patients on the less severe side, I think, they might kind of get through life with some, developmental delay, cognitive impairment. They might get sick here and there and have a few episodes that don't necessarily rise to clinical attention and miss that diagnosis. On the more severe side, I think most of the clinicians in this group can think of patients who come into the hospital at a very young age. They appear very ill. They might go to the ICU, and we were thinking maybe this is something infectious, and we never find an answer for it. And unfortunately, they pass away in our PICU, and we kind of say, well, maybe they had an infection that we just missed. I think we have some of those kids as well. But the kids in the middle, or the patients in the middle, those are the ones I think we're catching. So the question is, I talked about the more severe group. I think we need something like a newborn screening marker, or more genetic testing that's done in the inpatient setting to catch these patients. And then how do we catch the less severe? So certainly we can think about siblings, but this is going to kind of transition into the second part of my talk, where I think we need to be thinking about adults that might have missed testing when they were younger, just because we didn't have genetic testing available. So we have a patient, this is now published, and I'll post the link to this at the end. This is a 61-year-old male patient. His history is here on the left. So when he was a kid, he was hospitalized for this viral infection, presumed viral infection, that required him to go to the ICU, and he was very sick. We don't have records of this, but his siblings remembered it. He did recover from that, but when he was younger, he had these episodes where he was kind of fatigued and would sleep a lot or have a hard time moving and then go to sleep. So it sounds like recurrent spells. In school, he was switched between mainstream and special education classes. He did graduate high school, was employed for intervals of time after, unemployed at the time that we met him, and had been living with his mother, with his siblings assisting with his activities of daily living. And so he came to the hospital. This is 2 weeks before actually his presentation to the hospital. He started having some weakness in both of his legs. He came to the emergency department and was discharged home. They thought, oh, you have diverticulitis, which is just a kind of outpouching of the intestine. Got some antibiotics for that, and returned to the hospital because he was still feeling weak, if anything, a little weaker in his legs. So they checked a CK, which is a muscle enzyme test, and that was elevated. And they also checked an EKG, which probably was unrelated to the CK, but he did have a long QT interval. So this is probably sounding sort of familiar. His CK peaked around 6,000, and he got a kind of a workup for why is he having muscle breakdown. So CK is an enzyme that lives in muscle. When the muscle cells break, that goes into the bloodstream, so we see that it's elevated. He had an EMG done, which is a special test that we do in the neuromuscular world. And I'm going to see if I can play this video. This is a phenomenon called myotonia. And you can hear sort of this dive bomber sound. It's hard to see the waveforms here. But this is a phenomenon we see with a lot of different muscle diseases. Normally, when you poke the muscle with a needle, it's silent. And we see myotonia in only a handful of conditions, usually conditions that we think of as metabolic myopathies. It has that kind of dive bomber sound. So this prompted, with his high CK, genetic testing looking for metabolic myopathies and other genes that are associated with muscle breakdown. So they sent a rhabdomyolysis gene panel, and that returned a diagnosis, a genetic diagnosis of TANGO2 deficiency disorder. He was started on B vitamins after that point, and was doing fairly well, much better actually, discharged home and feeling like he had a lot more energy. I'll get to that, I think, here. So here's just some of the features. You can see the long QT interval in section D. In B, you can see a brain MRI. He had some volume loss there, but again, kind of non-specific findings. We call that on MRI. Interesting in C, this is a cross section of the thigh, and what's interesting here is there's a lot of fatty replacement of the muscle. So it's been reported out of Spain that some of the older patients with TANGO2 deficiency disorder might have some flavor of what we call myopathy or muscle disease, and that certainly bears out in this patient, having the replacement of muscle tissue with fat over time. So I didn't talk about his variant, but this patient had an exon 3 to 9 deletion, which is the most common genetic variant in TANGO2. But he also had a new, what we call missense variant, which is shown in blue here, the P-gly63 cis. So you don't need to worry about what that is, but you can just imagine that we're switching out one of the building blocks of the protein instead of a glycine, he has a cysteine, and that can change the structure of the TANGO2 protein. Now, we don't have enough data to say this for sure, but you can see that the blue variant where this patient's occurred is a little bit different from other missense variants that we know about in TANGO2, and those occur in orange. So we're learning more about, what are the important parts of this protein that might be doing the work inside the cell, and this one being a little bit further away maybe suggests the possibility that it could be associated with a less severe presentation. So again, this is my goal to, catch every patient with this disease, from the more severe younger patients, I think, that are presenting in crisis and we just never get an answer, to some of these less severe patients that probably missed their window of genetic testing when they were younger, and are out there. This is the paper if anybody wants to read this, and I just want to thank the foundation as well for paying for the open access publication fees. So this is available to anybody with an internet connection. You can find this paper and read it on your own, and I'm happy to take any questions. So thank you so much for your attention. Here's our Rochester group plus Dr. Lujan.
All right. Well, thank you, Dr. McKenzie. It's a really interesting update in terms of the movement disorders and kind of giving it like an interesting insight in terms of the potential for having long, productive lives within our patients that have TDD. There's a couple of questions from the audience. There's a question from the audience from our panelists is, did you do any testing for myotonia for like in DM1 or DM2 in terms of like myotonic dystrophy 1 or 2 related to this patient, considering the myotonic findings?
We didn't do additional, that's a really good question. We didn't do additional testing for myotonic dystrophy. But it's certainly, it's a reasonable thought. In this case, it would probably be myotonic dystrophy type 2, which is more rare. But no, we didn't. We had the diagnosis of TANGO2, but it's not something we would see on that gene panel. So it's a very good question.
And then there's a question from Dr. Gonzalez. Do you see that the variant that they have, the glycine 63 to cysteine, do you know why? Do you have any idea of like why this would have a little bit milder version other than just being in a atypical location? Do you have any other insights in terms of the protein structure or function?
It's a we did look into this. The amino acid change itself, with size and charge, and I, don't profess to be a structural biologist, but it did look like it would cause a pretty significant change. So that was the assumption, but again, we don't know because we haven't done the modeling. We haven't put this variant into a model organism, although we're certainly interested in doing that. We just have our hands full with other projects, but I think it would be interesting to explore some of these missense variants in some of the models that we're creating and working on and seeing what their functional impact is.
The other question I was thinking about is like in the combination from the talk just before us with Sergio and kind of the increasing pain tolerance plus this myotonic phenotype, do you think that provides any insight in terms of this atypical presentation of separating out the kind of ataxia dystonia? Do you have any sort of insight of like where the localization could be as you factor in this additional data? Is it more central? Is it more peripheral neuropathy as the potential means of having the TANGO2 spells?
I think that TANGO2 spells are really a black box right now. I think in an ideal world, we would have those patients in an fMRI machine with a, EMG electrode in their muscle and really looking at where that weakness is arising. I suspect it is more central, but it absolutely, I mean, we see different conditions in muscle where you have abnormal transport of different ions in the muscle that cause the muscle to be periodically weak. We call those conditions periodic paralysis. Um, so I think it's a really unexplored area. The weakness part in terms of the spells. What is going on there? I think there is a brain component, but can we rule out muscle involvement at this stage? No. Um, Definitely more work to be done figuring out what's happening with those spells.
Uh, we have a couple more minutes of questions. Amy Clay wrote like from the general audience is once muscle has been replaced by fat, can it be reversed?
So typically it's hard. When we have that degree of atrophy that I showed you on the MRI, it's interesting though. This particular patient never really complained of a lot of weakness outside of those episodes where he felt transiently weak. Um, so functionally, he was still doing pretty well. I mean, able to walk and move and get around his house just fine. It is hard though, once you see that degree of atrophy to bring a lot of muscle back. But there's certainly a role for conditioning because you can still regain some strength and functional recovery. So every time we're talking to patients with, muscular dystrophies or other more severe muscle conditions, physical therapy, keeping that activity level up, that's still a big part of the conversation.
And a question from Carolyn Dion, who has there's a 20-year-old who was diagnosed with TDD, but had the diagnosis of alternating hemiplegia of childhood until she was 19 years old. And I know that's been reported in the literature. What is your kind of understanding of like the movement disorder aspects related to the alternating hemiplegia, and how do those two things relate?
Yeah, I wonder, if we're calling the same thing two different names. That's my suspicion, but I don't know. I think that's one of the nice things about getting this project that Dina mentioned at the outset off the ground, where we can kind of convene as specialists in different working groups. And, is this alternating hemiplegia the same thing as spells, or is it something different? I think there are certain genes associated with alternating hemiplegia. These come back to largely calcium processing and calcium flow in the muscle and brain. And yeah, how that fits in with TANGO2 is a wide open question if we're seeing the same sort of issues with at the channel level.
Rolling back through the additional questions. I guess there was a couple of people that were asking like, how is this person currently doing? Any like changes since they were diagnosed?
Yeah, he's doing well. He hasn't been hospitalized. I think he's dealing with issues that come of being 61, probably unrelated to TANGO2, but feels maybe a little bit better in terms of energy, hasn't had any recurrences of weakness. So I would say overall, definitely better.